Hello, all. And thank you for joining Duke Science and Society for the latest installment of our coronavirus conversations. I'm sure, as you all well know by now, my name is Tim McDermott. I am the events manager here at Duke Science and Society. I'm coming to you live from Durham, North Carolina, home of the Blue Devils, obviously, the Duke Blue Devils. So just a few housekeeping notes before we have our exciting conversation today. The chat is open, and I want to encourage you to submit questions you have about COVID-19, treatments, symptoms, what the disease progression is like, to either Ben Shepard or myself, Timothy McDermott. And we will try and submit those over to our moderator, and we'll try and get to them. We also have all the questions that you submitted ahead of time that we are going to try and get to as well. So there's a lot of information to cover. Should we experience any technical difficulties, if you just go right back into your email and click on the link I sent, you should be able to get right back in. If you can't, you can head over to Facebook, where we are broadcasting this live right now, for anyone who is interested. So feel free to head over there. Finally, I want to encourage you to head over to the Duke Science and Society website. We have some exciting events in the hopper that we're planning right now. So be sure to keep up there with our event announcements. And you can also check out our MA in bioethics and science policy. The faculty and staff that we have on these conversations and the students we have on these conversations deal with these issues every day of the week. They are talking about these issues on a daily basis and trying to contribute to the policy and science conversations that we're having right now. And we would love to have you be a part of that if you're interested in studying that for, for a master's degree. We'd love to have you come join us. All right. Well, I want to get out of the way here, so I'm going to introduce our folks today. Dr. Nita Farahany, of course, is the leader of Duke Science and Society. In addition, she is the founding director of the initiative. She's also a leading scholar on the ethical, legal, and social implications of emerging technologies. She spent a number of years on the President's Council on Bioethics, advising the Obama administration on a lot of these issues. She's also the principal investigator of SLAP Lab and the co-editor-in-chief and co-founder of the Journal of Law and Biosciences, which right now we do have a special COVID-19 edition that Dr. Farahany rushed out. So please make sure you head over to our website and you can check that out. Welcome, Dr. Farahany. It's good to have you as always.
Thanks, Tim.
And
great to be here.
Oh, yeah. Dr. Cameron Wolfe, anyone who has spent any amount of time right now reading about COVID-19 knows Dr. Wolfe's name. He's quoted in every major publication I've found. He is a doctor here at Duke. He is a specialist in HIV infection, transplant-related infectious disease, general infectious disease, and he specializes in influenza and respiratory viral pathogens. Also, recently, he was named to the ACC medical advisory team that is going to be helping the ACC discuss how we safely reopen athletics in the fall. Finally, he is the leader of the Duke Remdesivir trial. So he is working with, Gilead Health Sciences and the other folks to see the effects of Remdesivir. And he's going to talk about that with us here today. Dr. Wolfe, it's great to have you join us.
Yeah, thanks so much. I appreciate the invite.
All right. Well, I'm going to hop off now and turn it over to Nita and Dr. Wolfe. Thank you all.
Thanks, Tim. Dr. Wolfe, it's a pleasure to have you here today, although here is there. Are you at Duke Hospital today? Where are we speaking with you?
So yeah, I'm in Duke Hospital. Again, thank you for the invite. This is wedged between my regular transplant clinic, my COVID ward rounds, and my regular transplant ward rounds. So I feel like it's a mixed fusion of everything that I typically do.
Well, we know that you're quite busy. Why don't I give you minutes to just kind of open up with any remarks that you may have, and I know we have a lot of topics we want to cover with the audience today. So handing it over to you, and then we'll go from there.
Yeah, well, and again, thank you. Look, it's been overused to say this has been unprecedented, but maybe the easiest bit to sort of describe how I came to be here and how we all fell into this would be to sort of look back at a little historical notes that we've done. I actually quite clearly remember sort of New Year's Eve flicking through my email cycles, and I get a list of updates of topical clusters of infections that might be popping up or issues that are cropping up across the world. And I actually distinctly remember looking at one from Wuhan and seeing a report from the Chinese media that there were 27, I think, folk admitted with an undifferentiated pneumonia. And I remember naively at the time thinking, oh, that'll be some kind of flu, or I wonder if that'll be a Legionnaire's outbreak or something that's unique to China. And I put it out of my mind. And sort of clearly as the next couple of weeks evolved, it didn't go out of my mind. Duke's had a kind of a unique position here in some sense that kept us on the forefront a little bit. We have a relationship with the University of Wuhan. We actually have a shared partnership there. And we have a campus at Kunshan, which is sort of roughly halfway between Shanghai and Wuhan. So we knew we had some early, not only people on the ground, but sort of exposures that were pretty unique by our standards. On any given day in the campus, we have over 1,000 Chinese citizens who are typically here. We had a tour group of Wuhan university students on campus in mid-January, a number of whom started to get sick with respiratory illnesses. So it was kind of on our forefront of our mind on the healthcare system pretty early on, and allowed us, I think in hindsight, maybe an early test kitchen almost to sort of see how we as a healthcare system and university would need to respond. Although honestly at the time, I think everyone was still very hopeful that this would be a really contained, isolated problem to Wuhan, Hubei, or broadly in sort of China and East Asia. I think what clearly sort of evolved as we headed into late February and March was the sort of deepening reality that was not going to be the case, and sort of moving the whole machinery to a mitigation strategy was obviously what everyone went through in March, and the hospital no different. It was kind of interesting because a number of us who had been in the sort of emerging preparative space for a few years, there's colleagues of mine who work in Emory or Nebraska or Hopkins or New York, and a lot of us have talked a lot about Ebola over the last 6 or 7 years. A lot of resources have been directed towards that as an emerging pathogen or similar sort of viruses where you really want to concentrate and hone in on a single person with incredible intensity focused on that one patient and tracing everyone around that one person. And yet we would sort of always have our end of our meetings with this kind of nagging anxiety that we were missing something, and that the miss was going to be we were hitherto ill prepared to handle a major respiratory pandemic. And I didn't know it'd be 2020. No one would have. You probably could have put money on it being a coronavirus or a pandemic flu, one of the two. But that nagging sense, unfortunately, has borne fruit in some instances. Although I think it allowed us to at least prepare in some ways ahead of time. And if I wanted to summarize kind of what it's been like now, it's been not only has everyone, no matter what your job, not just those of us in the hospital or the university, has been impacted, but there's been a social thing here that's been really unique. Like my wife does some work in disparities, and we've sort of commented that this has been something that has really uniquely in the last month or two, particularly within the United States, but I suspect elsewhere, thrown an uncomfortable spotlight on a lot of sort of medical and socio-economic disparities that exist here in the country. And it's not always been a comfortable light to follow. I don't know if you want to get into that as this talk evolves.
No, definitely. I mean, especially given this moment, right? I mean, the combination of the racial disparities and healthcare disparities that we see together with police brutality and injustice has made this crisis moment, that is beyond, I think, what anybody would have expected as well, right? So, I mean, I think definitely we'll get into that, I think, as part of our conversation today.
Terrific. So that's kind of my background. I've had I've had the privilege, I guess, of being able to be a part of some clinical trials that I think have proven both effective, but also I think helped to move our understanding of the way the disease clinically responds forward. You know, our university is similar to many. It can bring a lot of resources to bear in terms of trying to figure out both solutions for an individual person and then also some more broader public health questions that we've kind of struggled with a lot of our local counties and other health agencies. Yeah, lots still to learn though. I'll stop there.
Yeah, a lot to learn. I mean, I think that's been one of the hard things for the public is trying to understand the facts, right? I mean, I think as you know, filtered facts getting to the public, which is through an ongoing learning process, and at a time when peer review is happening with preprints, and you know, we have 2 major withdrawals this week of scientific papers based on a database that seems like a fanciful database that cannot exist. And so how do we,
way of describing it?
you know, it's reading some of the details of it, it, you know, seems unlikely to be an authentic database is a kind way of saying it. And so, you know, this, I think, conversation, we hope, is a chance for people to learn some of the facts that they're craving. And I can't imagine a better person to do it, since that you've been in the thick of it, but, you know, have been in the thick of it for much longer than this particular coronavirus, as you've been thinking about Ebola and previous infectious diseases that might have arisen. But focusing our conversations, let's start with the disease itself and what you've learned to date. So you've been treating patients at Duke Hospital. You've been in calls and on advisory boards throughout the world about the disease. And so based on, you know, kind of your description of it, could you give us sort of like a, here's what my perception of the disease is. There's COVID, the disease, there's the coronavirus, there's the particular risk of getting COVID-19 and having it turn into something, you know, from mild to moderate to severe. What does all that look like if you know, could put it into a short, easily understandable way for the public to be able to consume?
It's no small challenge.
Right, I'm aware. But.
Yeah, I mean, let's start off with what's clear. It's a respiratory virus, and we've been dealing with emergent coronaviruses in waves over many decades. So that part's not new.
Well, let me even just, I'm going to break them each down. So yeah, it's a respiratory virus, but, you know, recently people have been, you know, there's both memes going around, disinformation and misinformation saying, no, this isn't even a virus, it's a bacteria, it's vascular, it's not respiratory. Can you, like, when you say it's a respiratory virus, what does that mean? And what is that, how does that manifest?
Sure. So this is a virus, not a bacteria, not a fungus. It's a living thing that, like any virus, loves to harness onto our cellular replication mechanisms as the way that it divides. Mm-hmm. And so respiratory viruses, by their nature, have an affinity for binding and dividing comfortably in our respiratory epithelium, nasal passage, mouth, back of the throat, up and down the lungs.
And what about the eyes?
Yeah, so the eyes can be a portal of entry. We don't know a lot about how much actual replication is occurring within, say, tear ducts or within the orbit itself. Okay. But they can be a portal of entry for sure. And that's true, also true of many other viruses. Okay. What happens here is that I think a good comparison is to compare and contrast against flu. Most people have a good sense of what flu does. Similarly, respiratory virus readily spread by me bringing either on the surface of something I'm going to touch to mouth, nose, or lesser extent eyes, or I'm breathing in the air that contains droplets that get to that point. So coronavirus is, for the most part, contained on larger droplets. These are still microscopic, such that you can't see them. But the point is that if I cough such droplets, they are weighty enough to fall before they can spread throughout the entire room. Mm-hmm. So there's a proximity that's the first point that's important with coronaviruses. You need to be relatively close to someone to be capable of getting their respiratory transmission. And you need.
Well, let's get to transmission in a second. Let's describe what it is that's happening, and then I want to get really into the details of transmission.
Sure.
Because I know people, especially as the economy is reopening, everybody's like, "How am I going to get it? Where am I going to get it?" You know.
Yep. So number one, you can breathe it in. Mm-hmm. through those droplets that contain the virus within that little microscopic water droplet. Or you can touch it into your mouth or nose or eye. And then once in that space, the big contrast I think with flu that's important as this is borne out is that this is very slow. So there's a quite long incubation period. So the period from when I'm exposed to virus until when I first start getting symptoms is on average for folks somewhere between 5 to 8 days.
And during that time, are people contagious?
They may not know that they are, but yes.
Okay.
So I'll break that down. So let's say your incubation period is 6 days.
Right.
For those 6 days, you'll have no symptoms. You won't know you're sick. You'll feel fine. You'll do nothing different that would avoid other people.
Right. And this is by contrast to flu. What's that?
Contrast with flu, that's about a day.
Okay.
1 to 2 days. Very quick. So 6 day period on 5 to 8 day period on average, let's say 6. Probably 24 to 48 hours earlier than that, you've meaningfully started having virus replicate, divide, and be detectable within your respiratory tree and within your secretions.
Mm-hmm.
So technically, if I'm coughing, even in a point when I'm otherwise asymptomatic, in that day before I'm going to get a fever, I can pass it to you.
So there could be 4 days during which I would test negative for having the virus, that I am asymptomatic, but I am spreading the disease.
Well, no. So you'll only spread in that little bit of time, a day or two before your symptoms begin.
Got it. And at that point, would I test positive if you were testing?
You may, yeah.
Okay. And so at the moment at which I would start testing positive, that's when I would start to be infectious to other people.
Correct.
But before, if I'm testing negative, I'm not infectious during that period.
That's correct. Yeah.
Okay.
So ideally, what would have been great is that if I get exposed today, even if I'm asymptomatic, I get a test tomorrow and it tells me that I'm going to get sick.
Right.
Such a test does not exist.
Right.
So lots of people walk through that asymptomatic incubation period with no idea that they're going to get sick.
Yeah.
And particularly for the day or two prior to their symptoms beginning, may be capable of passing this to other people unbeknownst to them because they don't have symptoms.
Right.
So what becomes really important in that, and this is true of flu, but the whole timeline is crunched in flu down, is that if you want to break the cycle of transmission, you have to be able to get people who are, particularly those who are symptomatic, but also those who are exposed and going to become symptomatic,
Mm-hmm.
out of the way physically of anyone else who's at risk.
Right.
And that's what's proven so hard here, is that you not only, even to know who I've exposed requires me to look back many days and think of all the people for whom I've been around and who may have been close enough in proximity or extended enough in time to have had a reasonable level of exposure. And that's really hard to track.
Okay, so now you're exposed. Let's say you get sick, and let's just do the spectrum of disease from, the mild or even asymptomatic person to the most severe. And can you just describe that spectrum as you've seen it, as this has evolved?
Yeah, so there's probably the majority of people who are either asymptomatic or minimally symptomatic. So where that bore fruit for us was that in March and April, as we began testing all of our employees with minimum symptoms, we put it out there to say, we expect that young, healthy healthcare workers will have negligible symptoms and yet may be quite infectious to our at-risk patients or their at-risk parents or grandparents, for example.
Right.
So any sort of symptoms, come forward, we'll get you a test. If it's negative, we'll prove you can go back to the ward and keep working. If it's positive, we'll isolate you away. A great number of those people were surprised because they just thought they had mild seasonal allergies.
Yeah.
Or they had some mild headaches and fatigue, perhaps a mild sore throat, but nothing that they thought was even like a bad flu.
Right.
And so I think that's what people have to recognize, is that the body of the vast majority of folk who become sick fight this off very simply, get few or no symptoms, can be infectious during that period, absolutely. but don't recognize this as necessarily something that can be catastrophic.
Yeah.
That's more likely the younger you are. So it's not particularly a linear curve of age and severity. In fact, it escalates dramatically as you head into your 70s and 80s.
Mm-hmm.
And there's also some other features that I think are now we're beginning to understand are tied with severity. So diabetes seems to be a significant risk factor. Mm-hmm. Obesity seems to be a significant risk factor. And obviously those two run hand in hand.
Right. And any sense of why? I mean, we've seen some of these comorbidities that increase risk, but any sense of what's making those people more susceptible?
With the diabetes, I don't know. I'll be honest. I assume it has some sort of diabetes. We know has immunomodulatory effects in mm-hmm. terms of the way we control many immune system functions, and I assume on some level there's a risk factor that we don't quite have our fingers on. Obesity is more complex. I think there's both probably immunologic elements to obesity.
Yeah.
We know that there are, but I think there's also mechanics too. So if I am literally trying to lift extra pounds off my chest every time I want to take a deep breath with my lungs inflamed, that is mechanically harder. And it's more work, it's more effort, it's more oxygen consumption. And so I think, obesity gets people into trouble with many respiratory conditions, flu in particular, but that's certainly borne true here as well.
Okay.
Conversely, actually, one thing that we were really nervous about up front was other forms of immunosuppression. So our hospital, for example, has many transplant patients or chemotherapy patients.
Right.
They have not so much singled themselves out as being particularly high risk.
Interesting. Even if they're on immunosuppressants, like if they're on steroids or something, it's not.
Yeah.
They don't seem to get increased risk.
It's the story to fully be worked out. I mean, I'd prefer that they weren't on immunosuppression. Don't get me wrong, but I think our initial fear that this would in some way be really catastrophic in that group has not necessarily borne out. It's compounded by the fact that probably we as healthcare providers were very careful amongst that group to say, hey, there's this pandemic virus spreading, please socially isolate. And they were a group of people who, for the most part, are much more likely to do so.
Yeah.
So maybe there's also an exposure element there as well.
Maybe, yeah. So
I think
you have this spectrum of severity, which seems to be tied to comorbidities, but you also have people who've been quite young, right? Some in their mid-20s, even, locally, we had an elementary school child die a couple of days ago. There've been, I think the CDC reported that 10% of children under 5 end up with a severe form of COVID-19, although mostly recover, but end up with a severe form. So it seems like you're still seeing some effects in a younger cohort as well.
Yeah.
Is that largely individuals who have some, pre-existing condition, or is there anything that explains what leads to a younger cohort to have a higher severity of disease burden?
I'll concede I'm not a pediatrician, so I don't want to trump the opinions of some of my pediatric infection specialists, but I don't know that we understand yet in pediatric groups who gets the severe illness, or for that matter, why they are seemingly so sparsely affected by the severe end of the spectrum. I think what we've recently seen, and obviously that death is I mean, any pediatric death is tragic, let's be honest, but what we're starting to wrap our hands around is that pediatric infections can be both infectious to other people around them. So just because I don't have symptoms, or just because my child doesn't have any symptoms, doesn't mean they can't pass it to their grandmothers.
Right.
But similarly, there are some young kids who present actually after the infection has cleared with sort of an immunologic phenomena of an almost abnormal immune response spinning out of control after clearance of the virus has been achieved.
Is this looking like the kind of cytokine storm we see? And I mean, is that sort of what's happening here? Is it something, is there any explanation of what it is, or?
A little different to that. I mean, I think we believe it's probably cytokine driven in some way, but these kids are presenting with sort of multi-system inflammatory side effects akin to conditions called Kawasaki's disease, in fact, which has been a long-known inflammatory condition that starts up in kids of various etiologies probably, but reflects some of the immune derangement that actually occurs with COVID. Whereas in adults, what we see, and again, as a good contrast to flu, is that, you know, influenza makes you sick and you're better within typically 3 to 5 days.
Right.
A little bit longer than a common cold, but relatively speaking, quite short. In COVID, those who are becoming sick tend to have around the day 7 to 10, so already quite protracted. Some people who've been grumbling a lot at home with a bit of a cough and some fevers then really become quite hypoxic. They need oxygen. And it's quite a late phenomenon. And yet that always sort of sinks my heart when I see someone nowadays in the ED or on the wards turning up and they go, yeah, you know, I've been coughing for now 7 or 8 days. It's like right on the time when I believe their immune system is actually starting to abnormally respond. It may or may not have all that much due to the virus at that point.
Right. Kicked off by the virus, but probably not a viral process, something that's some kind of immune response to the secondary. You've commented that you have some concerns for that, especially people who have the severe form, or I assume this multi-system inflammatory response, that you're concerned that there may be some longer term effects as well. Is that right? That there may be longer term compromising of the pulmonary function in those individuals?
Well, I think I'm nervous about it. I think it should be studied.
Yeah.
I don't think the pandemic has existed long enough for us to know the answer, to be quite frank.
Yeah, we don't really have long term yet, right?
I don't have any long term follow. Like even if you grew up in Wuhan, you know, maybe you're at 4 months right now or 5 months. So, you know, part of what we tried here, and I know other groups are doing it in particular, was to set up survivor clinics is the wrong word, but like, you know, recovery clinics, I guess sounds better, where those kind of questions need to be answered. Like if you had really inflamed airways, what does that look like down the road? Does that recover completely? Does that leave you with scarring? Does that leave you with a stiffening of the airways? Or does it resolve? And I don't know that we know the answer to that yet.
Well, that brings us to some questions of treatments.
Sure.
You're at the forefront of work in this area, from the Remdesivir trials that you're heading up at Duke, to EC18, to, you know, vaccines that you've been looking at. I know everybody thinks the holy grail is, you know, a vaccine, but I think, you know, it's a while before that will pan out. And so what we really are looking at in the meantime is if we have really effective treatments, you know, even if there's some delay to getting a vaccine, the impact of the disease may not be as severe on society, right? And so, so which one of those would you prefer to start with, the Remdesivir, the EC18, or the vaccines?
Well, let's start with Remdesivir because we know more about that than the other two.
Great. So I mean, there's been a huge investment by the federal government in Remdesivir and trying to scale it up. Can you tell us, what are you seeing with its, you know, use cases? You've been studying it for both moderate as well as severe, right? And so, you know, how has it been faring? How does it work? And, you know, how hopeful are you in it as a potential treatment?
Well, I think it's demonstrated that it can be a good treatment. And then let me tease that apart.
Okay.
So, you know, it's a broad spectrum antiviral that actually was tested originally for Ebola and didn't prove very effective against Ebola, but we learned a lot of safety data about it from that. And so in this context, I think the accumulation of both some Chinese information, some data driven through Gilead themselves, through some private trials, and then also through some publicly funded NIH trials that we participated in both of those. I think you could wrap them up with the following statements: is for an intravenous drug that therefore by definition really at this stage has only been studied in the sickest population who land in a hospital. It's not an outpatient therapy.
Yeah.
We can get to those later. It seems to be effective at shortening the duration of your illness, with lots of benefits therefore about getting people back on their feet and recuperating and recovering quicker.
Now, are these people who are on respirators, or these people who are not that sick yet? Like when we say the kind of severe and sick population who are getting it, who are they?
So it's the whole group have been studied, from people who are barely in the hospital with a few fleeting X-ray infiltrates but not requiring much oxygen, all the way through to people who are on ventilators and heart-lung bypass machines because their lungs are stiff. Where it seemed to find a sweet spot, teasing the data apart, was in folks who were treated early. The longer you, and I think that makes sense for any antiviral or antibiotic, the sooner you get it into folks, the better they're probably going to do. And for folks who were severe enough to likely need to be in the hospital for a while, and yet not so sick as to have already been in the hospital for 2 or 3 weeks on a ventilator struggling. Like, this has probably missed its sweet spot as a salvage drug. So, you know, I think when we see folk who come in through our emergency room, they're deemed to be hypoxic or ill enough that they are, you know, needing hospitalization support, and it doesn't look like it's just going to be a sort of an overnight admission to top up their fluids and give them some Tylenol, send them home. Then this drug has shown in randomized double-blind placebo trials to be better than any other standard of care at getting you better quicker. Now, they were not powered as mortality studies, so to be clear, they have not demonstrated yet that there is a statistical mortality advantage. But when you looked at the trends of mortality, they on average went from about 12 down to about 8, so that's a benefit. Where it seemed to be, again, less effective with the people, well, no different than frankly not giving it, with the people who are either really well and just in the hospital for a day or two, or really, really sick and we'd probably miss the boat. So, you know, that was Fauci's assumption.
Do you have any sense of, is it because of the damage that has already occurred as a result of the disease? Is it because the viral load is too high and the dose needs to be higher? But do you have any sense of sort of, when you say miss the boat, you know, what's happened that makes it ineffective at that stage?
We don't perfectly know. So that NIH data is still going back through viral loads, for example, to see what impact this drug had on the amount of virus that you shed. My suspicion is that you've just had structural damage at that point significant enough that there's not an antiviral impact that's going to make a difference there.
To the lungs, to other organs.
So that's its role. I mean, I think it's not a panacea. It's a helpful advantage. I mean, I do legitimately think we've seen people trending to getting better quicker in the last month or two when we've used it liberally, as opposed to those first waves of people we saw in March.
Well, so, you know, there's been a lot of media discussion about anti-malarial drugs, and renewed interest after the major New England Journal of Medicine study has been withdrawn. But one suggestion, I think, of that drug is that it could be prophylactic. People could take it, you know, and it would be something that might safeguard them. So, you know, are people talking about Remdesivir really still only for that severe population? Is there any benefit to people with much less disease, you know, kind of burden taking it? Should everybody be taking Remdesivir? You know, would the children who have the secondary effects 2 weeks later, if they were on Remdesivir, would they avoid it? I mean, you know, how are people talking about the role of Remdesivir in treatment of COVID-19?
Yeah, I think at this stage it's really limited the discussion to sick inpatients. There's not a substantial pediatric experience yet. There's a growing experience in pregnancy. That's its own little cohort where it seems to be safe. I think with the kids,
seems to be safe during pregnancy.
Correct.
And I've read that there's, you know, they found it in the placenta of mothers, and so. Yeah.
So from a toxicity point of view, and that's very preliminary data, and I don't mean to speak out of line on that one. I think what we don't know is we don't know if treating kids prevents the immunologic derangement that may come with multi-system inflammation. In fact, we don't know who's going to get that, so you don't know who you would want to treat with an intravenous drug with some side effects.
And can it only be administered intravenously? Is there some effort to have it be something like Tamiflu, that we can, you know, as soon as you get sick, you get Tamiflu, and maybe as soon as you get sick, you get Remdesivir?
There's not those efforts driving at the moment, and my understanding of its sort of molecular formulation does not lend itself favorably to like pill form, for example.
Mm-hmm.
I mean, you could see a world where you could say, look, hey, there's an antiviral here that we know is effective and it seems to control the virus. Why don't we give it as soon as your first symptoms arrive?
Right.
But then you get into all the mechanics of, well, like, how do we give an intravenous medicine to every person who's exposed? Like that seems.
And do antivirals have the same concerns as antibiotics in terms of driving resistance and mutations?
Yeah, they can. There's a long history of antiviral resistance in respiratory viruses.
Mm-hmm.
You know, we know that exists in flu. We know that exists in respiratory syncytial virus, RSV.
Mm-hmm.
We don't know if that really exists here in COVID yet. There's clearly been some data looking at sort of strain drift over as different strains have emerged and spread throughout the world.
Right.
I don't know that we know sufficient information about whether that has been driven by the administration of drug to comment yet. They're ongoing studies.
I'm sure we're going to get more questions about Remdesivir, but I want to hit on EC18 because I think it's one that people are less familiar with. And you're also heading up efforts on EC18. So could you explain a little bit about what that is and where that fits in the kind of spectrum of treatments that are currently under development?
Yeah, I mean, that EC18 is one drug out of many that have frankly been targeting the immune side of the illness.
Yeah.
You know, you've got antivirals targeting the virus, and then there's what about your deranged response? And so that's where this hits in, along with many other chemotherapeutic agents and a lot of other anti-inflammatory and immunomodulatory agents that we can get into the weeds to if you want.
Mm-hmm.
You know, most of those therapies are strong immunosuppressants.
Mm-hmm.
They dampen down your immune response with the theory, and some data to support it coming out now, that there is an adverse sort of proactive inflammatory response that comes late with COVID. Maybe that's what's driving that day 7 to 10 deterioration in hypoxia. And can I turn that off transiently? Obviously, there's importance in having your immune system, but can I temporarily cut it down? And so, for example, the second version of the NIH Remdesivir trial brings that on board. It says, right, we've proven Remdesivir works. Now let's have that as the standard of care, and let's trial the addition or not of a strong anti-inflammatory.
Okay. And is this different than a steroid? Is it different than the chemotherapy drugs that are immunosuppressants as well? I mean, is it more targeted and specific? Or?
Yeah, they're typically much more targeted. So these are often monoclonal antibody targeted drugs that try and hit specific cytokines, specific T cell receptors. They usually
already know are implicated in COVID-19 that are more specifically being amplified in COVID-19?
Yeah, so that's where things get a bit murky. So when you test a whole bunch of cytokines in someone who's sick as stink, you'll find things that are elevated.
Right.
And whether that is causal or just a byproduct of the degree of viral triggered inflammatory response isn't perfectly clear yet. And so, and yet they're a target that seems to be more highly elevated in those who are more sick. And so the question that's a valid one is to say, well, look, maybe some of the damage that I'm seeing here is because you've over-enhanced your immune response. Can I bring that back?
Right.
So what EC18 does is it's a different kind of therapy in that regard. It's been available in South Korea actually for a long time as rather than an immune suppressant or like turning off a particular pathway, it seems to have an action to bring back immune homeostasis. So the sort of the leveling off and normalizing of someone's immune response. What's not known again, like those other anti-inflammatory drugs, is that beneficial in COVID? But it's a valid question to ask.
So
lots of drugs.
Before we get to vaccines, this is a sort of the treatment, part of the conversation.
Yeah.
Given where we are now with treatments versus where we were at the beginning of March or, in kind of mid-February, are you feeling optimistic about, about this disease and disease burden relative to flu or RSV or other kinds of respiratory illnesses? Are you, we're seeing the numbers still increasing. So, do you feel like it's less of a big deal? It is just as big of a deal. It is, we have treatments coming on board and you're more or less concerned about it, just trying to gauge your level of optimism or concern in light of treatments.
So I feel more comfortable when I meet someone in the hospital who's already quite sick by the definition of being there, that I can turn their course around.
Okay.
Not for everyone, but I think we're all more hopeful that in fact we're seeing people get better quicker. And that we know a hell of a lot more than we did 3 or 4 months ago.
Right.
What I'm not confident about yet is, if you today were to develop symptoms of COVID, is there anything I can do to prevent you needing hospitalization? And currently the answer to that is no, other than, isolate yourself to protect others and make sure you keep up your fluids and hydration. That we don't have an outpatient therapeutic for this. Nor do I know of any that are near to the market, to be honest.
So if you had a particularly at-risk patient, like suppose that I was obese and have diabetes and maybe high blood pressure, whatever, give me the full constellations, I have all of them. And I come in and so far I'm doing okay. I've got a sniffle, I've got a backache, I've got a headache, I've got a little bit of a sore throat, but I'm in the highest risk category. Now also make me 75. Are you going to put immediately on Remdesivir, or are you going to wait until I get sick?
Yeah, currently we'd wait actually, because when we looked at the stratification of illness in that study of Remdesivir through the NIH, actually people who are on the most mild end of the spectrum, irrespective of whatever risk factors they brought to the table, didn't do any different.
Yeah.
So there's been some work here looking at, what's the optimal treatment there? It would have to be a pill, wouldn't it? Because I can treat you then before you need hospitalization. Right. So there's been some people who've looked at hydroxychloroquine in that section. So we can get into the politics weeds if you want there.
Yeah.
And then there's been other, there are other outpatient pills that seem to have had some historic activity. So for example, some of the HIV treatments, ironically, as antivirals, have hypothesized activity against this particular virus. They've not proven very effective yet. And in fact, another study just today from a UK treatment group looking specifically at hydroxychloroquine, they in fact closed a many thousand person study because they showed that in fact they have no chance of showing that it is beneficial. So now that's in
and there are side effects, right? So and there are side effects, right?
Yeah, this particular one did not show side effects as being meaningfully different.
Okay.
The Lancet study that you were talking about earlier, I think, that was withdrawn in the last 24 hours, did in fact cause commotion because of a very large safety signal. Data.
We're going to set that one aside, given
data validity notwithstanding.
Yes.
There's 3 situations where you might think of using a drug like hydroxychloroquine. One is to treat sick people.
Right.
One is to treat people who you know to have been exposed. And the other group is to treat people who may not yet have been exposed, but you think they're at high risk, like a healthcare worker.
Right.
And there is now data emerging also for the treatment of exposed individuals. University of Wisconsin actually put out Minnesota, I beg your pardon, put out a recent paper in the New England Journal just this week showing, actually doesn't seem to help. But there's still a little bit of science, I think, still left unanswered for some of those folk who may yet to be exposed but are at its highest risk, with some theory that hydroxychloroquine may still have a role to play there. But I think its position in the armamentarium is thinning by the day. Let's say that.
You're not taking it to protect yourself.
I'm not taking hydroxychloroquine to protect myself at the moment, although there is a valid trial that's ongoing to look after healthcare workers. So my choice should not invalidate that study by any means.
Understood. Okay, so then let's talk about the vaccines for a moment. Lots of people are putting lots of hope in the vaccines. The Mrna results from a very small cohort of phase 1 seem to show some safety based on the data that they've released. For the 8 patients that they had tested, they said that there were neutralizing antibodies, but this was tested in the lab, not by exposing these patients to COVID. So we don't know if they would have, if exposed to COVID, if they would have immunity and what might happen. And you've expressed some concerns about both the lack of safety data, but also longer term, trying to understand what we might see in the patients and the research subjects, what kind of data might emerge. So I was hoping you might weigh in a little bit on that, because I think there's hope, but in many cases kind of desperate hope, right, for the vaccine. People are so hopeful about being able to get back to their lives without fear that the vaccine is, I think, where people are placing a lot of that hope. So what are the things, I guess, what are the cautionary tales about a phase 1 study of this kind to help dampen the enthusiasm a little bit, but also maintain the hope? Like, where are you seeing things?
I mean, I would start by saying I don't want to dampen hope in vaccines. My hope is in a vaccine, I'll be honest.
Yes.
And I say that because there has been unprecedented reshifting of everyone's cogs towards trying worldwide to come up with a COVID vaccine.
Yeah.
So if we're ever going to have success, it is with a massive restructuring organizing that has focused on that singularly.
Massive sharing of resources, huge resources being
sharing of resources,
sharing of data.
Absolutely, absolutely. To the point where it has brought up so many interesting political questions of how you share data and who should take ownership, and like lots of stuff that we could talk for.
No, which I think are really interesting ones. In fact, one that we ought to have a coronavirus conversation on, because it's an unprecedented moment to think about the sharing of data, what rights should, if any, exist in whatever therapeutics are developed. But we'll cabin that for now. Invite you back for that conversation, and agree with you. We don't want to do this, but I do want people to be tempered a little bit in their hopes so that they're not misguided about early data that's released from a phase 1 study.
Sure. I mean, so the phase 1 data that's out there so far comes from 2 main types of vaccines, although I guess 4 main companies, but there's actually a litany of other vaccines that are sort of moving their way through. The couple that are moving along the fastest are either mRNA vaccines. Mm-hmm. So these would be the first RNA vaccines that we have. It's a new technology. It's a technology that has advantages in terms of its potential pace of production. It doesn't require live virus to create the vaccine in the first place. So there's lots of real end advantages. But these are at the stage where we are solely testing them. This is the Moderna vaccine, for example, solely testing them to prove that they stimulate a comparable immune response to what recovery from the virus would have looked like.
Now, can I just pause you there for a moment to ask you a question, which is, given our conversation earlier, which is a secondary effect in some people is an inflammatory response that doesn't seem to be connected to the disease itself, could you see that with a killed vaccine like this or an mRNA vaccine like this, could you, it's been a tiny study so far. Is it possible that we might see with some of the people who get the vaccine that kind of a response?
It's possible, yeah. I mean, I hope unlikely in reality, but I think one of that speaks to my first unanswered concern yet. I don't have any reason to think that these will be worse than others, but I think with any vaccine study, you want to not just look to see, does it stimulate the immune system? And these seem to have done that. Mm-hmm. But what's the longevity of that stimulation? Does it come with side effects? Yeah. Is in fact the immune stimulation counteractive? So some of the dengue vaccines, for example, in fact seem to enhance future dengue disease manifestations because your immune system was already primed to derail itself the next time that virus came on board.
Yeah.
And so we all think a vaccine stimulating our immune system must be protective, but that's assuming the stimulation, as you say, is directed in a protective way, not a deranging way.
So how do we find that out with a vaccine if we can't expose these people who are getting the vaccine to the virus itself?
It's tough. You have to at some point come up with the next step of a trial, which is, right, you've mounted immune response, now do you get sick?
Right.
And do you do that through a challenge study where you inoculate people with virus, or do you send them out in the community for 6 months and measure how many of them got sick and to what extent?
Both of which seem ethically problematic.
Sure, but at some point you've got to test whether there's an efficacy benefit of sticking.
Agreed. There's also an ethical imperative for us to have a vaccine, but
we've got to get a vaccine. But these are the kind of next phases that a vaccine, just because it stimulates an immune response, doesn't mean that immune response is necessarily protective.
Right.
In fact, that's one of the challenges with coronaviruses in general, is that there's been quite a wide variety of protection that they have engendered from our own immune response historically in the past. Some are very strong immune stimulators and others are quite weak. And so just because a vaccine creates a similar immune response as would a natural infection doesn't mean it's going to stop you getting another one.
Right.
And so you go through phases. You go through phases of, does it create the immune response that you hope it does? And I think the answer to these at the moment is yes. Is it durable? I don't know.
Right.
We haven't followed people long enough.
I mean, we don't know if people who have recovered have durable immunity either, right? So
correct.
Yeah.
We're looking to see, can they get reinfected? There's some cases where it's suspicious, but few and far between.
Right.
Is it safe? And then the biggest, like, if you prove it's safe, it's effective, and it lasts for X number of months, then you can start saying, right, so do we incorporate it with a yearly flu shot?
Right.
Last for 5 years, and we incorporate it with a 5-yearly meningitis vaccine, pneumonia vaccine, sorry, for our elderly. Like, how do you use it?
Right.
And then the biggest question is, how on earth do you manufacture it for 6 billion people?
Right.
And so, the typical timeline for a vaccine development is years, if not decades.
Right.
What's happening here was one of the other companies doing a lot of work here is the University of Oxford and AstraZeneca in the UK.
Right.
And I actually had some press releases just today about ramping up further testing. And one of the things that they and others are doing with a lot of government and super governmental organizational support is to say, we're going to start ramping up our manufacturing capacity even before we've proven that this is effective, because there's such a time urgent need for us to get this ready.
Right.
And so you'll sit, rather than a standard trial of a vaccine going from preclinical to phase 1 to phase 2 to phase 3 to production, these are all overlapping intentionally to try and move things along quicker.
So would you get the vaccine if it came? I mean, suppose it by end of December, where the belief is there may be 100 million doses. You're high risk, right? I mean, you're having to gear up with extraordinary personal protective equipment in your daily life. Would you be one of the early people to get a vaccine?
I think there's a resource allocation question to that.
Suppose we decided that people who are in high risk positions like yours should be ethically one of the first to be offered the vaccine.
Okay, well said. Sure, I think that makes perfect sense. I mean, both because I think the science would by that stage have moved in the right direction, and a vaccine makes a lot of sense in that setting. I think you do want to keep frontline healthcare workers primarily protected, and or highest risk individuals. And frankly, I have no concern being a part of research that helps future folk learn more about what the response was. Yeah, so yes is the answer.
All right, well, good. We don't have too much time, and there's a lot I want to cover with you still, but let me suggest this. One is, I would invite our audience to look into your work with the ACC. I know a lot of people at Duke want to know, are we going to have basketball next year? But on a more weighty conversation, rather than getting to that one, we're at this moment in time where, at least in the United States and even worldwide, there are protests and demonstrations because of the injustice that we've been seeing with the deaths of George Floyd, with the multiple other, insults and racism that have been so pervasive in our culture, both recently and historically. And that raises two questions for me that I hope you could address here with a little bit of time left. One is that we're seeing a disproportionate effect, both I think in the severity of the disease and the transmission of the disease, at least numbers and counts on African American populations in the United States. And the second is, I think a lot of people are wondering, as the models are revised, as people pour into the streets in protest of these horrific injustices, are we going to see a spike in transmission of the disease, or are we at the sweet spot of the summer and higher humidity and higher temperatures where maybe that'll be the saving grace to enable people to be able to protest without fear of a much wider spread burden of disease on society?
Yeah, okay.
So I guess the first is, do we have any insight as to why? Is it,
sure.
You spoke earlier of like your population of organ transplants recipients, having early access to medicine and early access to healthcare and advice. Is it a socioeconomic disproportionate healthcare? Is it all part of the same, right? Or is there some other explanation that's emerging as to why the disease burden has been so much higher in a particular population?
Yeah, I mean, I'll preface this whole section of this discussion by saying, as the white guy who didn't grow up in America, I have like lots of emotion still about the last week and a half, and yet I can't begin to imagine what is going through other people's mind. And I don't, whatever I say here should bear no inference that I am for or against folk protesting. I solely can approach this from a position of understanding the medicine and the epidemiology.
Appropriately and fairly
the tragedy is human and horrific, all in one. So I'm trying to learn from that front. Let me split by saying a few things. So there definitely seems to be a disproportional impact both on African Americans and frankly Latino populations, which I think sometimes get missed in these conversations. We understand a fair bit about that, I think now, but imperfectly. And I think you mentioned both socioeconomic complications and triggers. And I suspect they make up the vast majority of why we see disproportionate impact, both in terms of social phenomena such as employment in much harder to simply go and work from home. Challenges in terms of being able to socially distance and yet still keep up a paycheck to paycheck scenario. Or types of work that in fact put you face to face with many more people, for example, in service industries. So I think that there's an exposure question there. That's number one. And then I think there is, sadly, I think a health literacy and health availability issue that comes to play there.
Yeah.
Do you hear the same, do you get the same message with the same impact about protective health? And then I think the third thing is, if you're going to get infected, what's your outcome going to be? And I think there's, when we say there's a disproportionate impact to, for example, obesity, diabetes, probably smoking and airways disease, they do not follow that. There are racial differences and ethnic differences along those lines in the United States that are quite stark.
Yeah.
And so when I look through the list of my inpatients here, for example, we are disproportionately impacting our African Americans and our Latino populations for sure. Yeah. And the rates of diabetes and obesity within those inpatients are high. Yeah. Density of living situations is different even for some folk. And what does that mean? It means greater exposure. So I think for the most part, it's socioeconomic. What's harder to tease out are there little genetic differences there that might be separate as well. And there's some talk, for example, of cellular differences related to a component called ACE, which is a renal device that can perhaps make African Americans greater risk. That's less to be teased out.
And the last question, even though we're over time, is
sure.
Protests. Understanding you are not, you're not commenting on whether or not people ought to be protesting. but simply, do you have concerns about increased transmission as a result of the protests that are happening?
Yes. You know, I think if you think of all the things that lead this virus to spread readily, it's close proximity, it's expectoration of viruses, and what are we doing if we're either A, shouting, or B, coughing because we've been exposed to tear gas. Like that's a perfect environment for that. And so like on the one hand, I'm heartened to see a lot of people protesting, and frankly, police and security officials on the other side also seemingly taking good mindful steps about self-protection. Like there's a lot of mask wearing in that group, and that's, I've seen people with their Purell bottles hanging off their belt. Like there's way, or sit-in protests that have been publicly shown where folks have managed to social isolate themselves across an entire large wide park. So I do think there's ways that you can still demonstrate your involvement in the issue, but to do so safely. Because I think the reality is for many states, particularly ours, you know, this is coming at an increasing high water point in terms of disease burden. Our hospitals are full, and we are better at trying to get the message out about how to protect people, but that's occurring at the same time as we're trying to reopen, which we have to at some point. And what that is currently resulting in is it's not a massive surge like we saw in New York, but a steady increase in cases. And I think as if the last week of protests ends up bearing true that will cause an increase in case burden, we may not even see it for a couple of weeks. And my concern is that, like, let's say you're exposed at a protest today. Like we said, it's a slow illness. You won't become symptomatic potentially for a week. And I think the people who are protesting are probably not the highest risk, but I think their parents might be, or their grandparents. So you have to go through your incubation period, get sick, and then infect someone else who I suspect will probably see the secondary cases as a fallout from protests. So yes, I would be very cautious that we won't see infection transmission. I think it's inevitable. The other way that COVID just real quickly ties into this, I'm dead sure, is like, let's look, we've all been collapsed in, huddled, like socially isolating, losing our jobs, stressed. I think the sort of bubbling background level of tension is just higher. And then you throw something as horrific as this into the mix. I just think that I don't know. That's my sense. That's not driven by
the spark in the vacuum, right? I mean, it's
maybe.
Well, this has been such a rich conversation. We're so grateful for your time. We're so grateful for you being on the front lines of treating patients, of discovery of treatments to help guide us through society, of chairing so many different both studies and commissions to try to help society through this. Thank you for taking time in between what we know is such an incredibly hectic schedule to be with us today, to share your wisdom, and thank you for educating us as well as you have today. Thanks so much for your time. Take care.
I really appreciate this.
Thanks to everybody for joining us. Please tune in next week. Dr. Wolfe touches exactly on what we hope to touch on, which is looking at the spark in this moment of time and what the implications of that are for both the disease and for society. Take care. Thanks.
Thank you.